I am unable to share my screen. Please allow that.
Yeah, try now.
Mas, good morning. You can start your presentation.
Yes, sir. Good morning, sir. I'll be presenting about indications and complications of elbow arthroscopy. Is my screen visible and am I audible, sir?
Yes.
Starting with the introduction of the elbow arthroscopy, the article by Caris and Bennett Co. Published in Journal of Arthroscopic Surgery and Sports Medicine, while explaining about the introduction of elbowscopy, they said that the challenging part of elbow arthroscopy is that it's confined space and its proximity to neurovascular structures. So, with early 1900. So with the advent of arthroscopy and its popularity in knee, it was extended to elbow. But orthopedic surgeon Dr. Berman from US concluded that it's unsuitable. This joint is unsuitable for elbow arthroscopy, owing to the size of the scope and the needle, which is very large for this confined joint. So over a period of 40 years, there was modifications and a decrease in size of scope that it became suitable. In 1971, wherein it was again started by Dr. Masaki, a Japanese orthopedic surgeon, and the 1.7 mm scope was popularly used from that time. And as of now, various elbow pathologies can be addressed by arthroscopic procedures if until and unless they want extensive bony procedures. And obviously, the advantage of arthroscopy takes upper hand over the open surgery, that it's minimal invasive and early post-operative rehabilitation and return to sports or work would be better in arthroscopic procedures than in open procedures. Coming to the topic proper, this article by Shaw and while speaking about the elbow arthroscopy indications and technique, published in Journal of Clinical Orthopedics and Trauma, they suggested that the first and foremost indication for elbow arthroscopy are loose bodies around the elbow. These loose bodies can be because of osteochondritis dissecans, it can be because of synovial chondromatosis or trauma. Or OCDs. These loose bodies can be of varied clinical features. Sometimes there would be they would be asymptomatic, which does not warrant excision, or if they are symptomatic that they are causing pain, swelling, and restricting their range of movement, then excision of these loose bodies is warranted, and arthroscopic procedures are promising in managing these kind of features that they increase the range of motion, or they release the restricted end range of motions. Second indication for arthroscopy is early arthritic changes. This is little contrary to the arthritis which is managed in other joints of the body, that this article by Desmoinex and Co. While explaining about the management of early arthritis, elbow arthritis in by arthroscopic management, published in Orthopedics and Traumatology, they suggested that early arthritis changes can be managed very well with arthroscopic debridement and other procedure, which I'll be mentioning about. They did this study in 87 number of patients, wherein 90 to 95% of the patients had satisfactory outcome in terms of better ROM and pain. The procedures of the arthroscopic technique in management of early arthritis would be in terms of olecranon trimming, or the coronoid trimming, or the fenestrations of the radial head and the humerus, or capsulotomy or capsulectomy. These are some of the arthroscopic pictures of arthritic elbow, wherein osteophytes and the chondromalacia changes can be seen in the trochlea as well in this peak. So we have to keep in mind that managing arthritis in elbow is little in contrary to managing it elsewhere, that these procedures, arthroscopic techniques, would give a favorable result in elbow arthritis than elsewhere. Third indication is arthrolysis. As we know that the stiffness in the elbow can be traumatic or atraumatic. It can be in traumatic, it can be because of fractures or dislocations or burns. In atraumatic causes, it can be because of synovitis or heterotrophic ossifications. That if there is restriction in the elbow movement, we all know that pronation is the movement which we require more because of its position in typing, in eating, and supination is required while holding a plate. So if there is a restriction of pronation in the elbow, this will be compensated by abduction and internal rotation of shoulder, more than the compensation for restricted supination. So the options available in arthrolysis can be excision of osteophytes or removal of loose bodies and release of the capsule. So this has a promising result to be managed by arthroscopic way, but the various authors have suggested that while managing arthrolysis, if we are unable to achieve the ROM, so we should hold a low threshold to open and do a thorough arthrolysis so that the elbow is in a functional range of movement. Various authors also suggested that we should always keep in mind, if at all the restriction of flexion is more than 100, then ulnar nerve would be at risk that it would be tethered behind. So releasing the ulnar nerve or anterior transposition of ulnar nerve would be warranted in these kind of procedures. Fourth indication is managing the OCD of capitulum. As we know that this is the osteochondral separation from the subchondral bone of the capitulum due to repetitive microtrauma in adolescents who are weightlifting and in baseball players. So these osteochondral lesions can be stable or unstable. Stable procedures can be managed. Stable OCD defects can be managed conservatively with guarded with restricted ROM initially, and then subsequently a thorough physiotherapy treatment. But if that is unstable, that it's in the form of a loose body and cartilaginous defect, that would warrant an arthroscopic procedure of debridement, be it micro drilling or bone marrow procedures or the autografts. This article by Christian and co published in World Journal of Orthopedics in 2016, they suggested that managing the OCD of capitulum had a favorable result, that about 90% of OCD patients in their study went to pre-injury level of sporting activity. So this OCD pathology can be very well managed arthroscopically. The next indication is lateral epicondylitis. As we know that ECRP is the most common tendon which is in question in this pathology, but there can be just inflammation, or there can also be a tear in ECRP tendon that would give the patient features of lateral epicondylitis. This article by Kalainov and co, while explaining about the comparative results, they suggested in this article that the arthroscopic procedure of management of lateral epicondylitis is similar to the open procedure in long term, but in short term, obviously the arthroscopic procedure takes the upper hand of being minimal invasive and having better post-op outcomes. So the author also suggested that if the lateral epicondylitis is associated with instability or ulnar nerve symptoms, that is a relative contraindication to elbow arthroscopy. Valgus extension overload syndrome. In this article by William and co, while explaining about the pitcher's elbow, they did excision of loose bodies and management of elbow osteochondritis dissecans and chondromalacia, they suggested that 85% of the patients, wherein 56 was the sample size, 85% of them had a favorable outcome and they returned to their sports activities. So in valgus extension overload syndrome, as we know that there will be a valgus stress and compression on the lateral side and tension on the medial side with olecranon bony spurs. So excision of these spurs and managing of OCD and chondromalacia changes in the trochlea and the OCD of capitulum would give a favorable outcome results in these kind of patients. Fractures, some fractures are also can be managed by arthroscopic means of excision if there are comminuted olecranon or coronoid fractures. Excision of them would be done by arthroscopy, though their advantage is limited and they are managed conservatively. Some contraindications nowadays, there is no absolute contraindication, but relative contraindication to elbow arthroscopy is that the clinician should be well versed with the anatomy of the elbow joint if that is distorted due to previous surgeries or ulnar nerve subluxations or transposition of ulnar nerve done previously, and also active infection is a contraindication to the elbow arthroscopy. Coming to the complication part, this article published in JBJS explaining about the complications of elbow arthroscopy by O'Driscoll and Co. They retrospectively studied 473 elbows in 449 patients over 18 years of time, wherein they divided the complications into major and minor. They suggested that only 4 patients, which amounted to 0.8% of the patients, had major infection which was deep-seated into the joint. Majority of them had minor complications, wherein 50 patients had that, which amounted to 11% of the patients. Among them, 33 patients suffered superficial infections, and 7 patients had FFT of less than 20 degree, and 12 patients had transient palsy. In 10 patients had transient palsies, which in 12 nerves. So ulnar nerve was most commonly affected. Five patients had ulnar nerve complications, and 4 patients had superficial radial nerve complications, 2 for PIN and 1 for AIN palsy. So there was some overlap between complications, wherein some of the patients had 1 or more complications. So there is overlap in this. So the author concluded that the risk factors for the complications is that the clinician should be well versed and trained while managing pathologies by elbow arthroscopy, and if there are any ulnar nerve pathologies like subluxation or the anterior transposition, which if it was done before, this should be sought, and they should be kept in mind while placing portals, that we don't injure these structures intra-op. This article by Ahmad and Co, while explaining about the complications of elbow arthroscopic surgery, they did systemic review and meta-analysis published in Orthopedic Journal of Sports Medicine. They did by PRISMA protocol, wherein 1208 articles were taken out, and after scrutinizing, at last they reached 95 studies, which included 14,000 change elbows, out of which 11%, 1,136 elbows had complications. They divided the complications into 2, those with the compromised ROM and those with soft tissue complications. They came to a conclusion that out of this study, 4% had stiffness, which was most common, and 2.6% had instability complications. Coming to the soft tissue complications, 2% had superficial infections and 0.8% had deep infections, and 3.4% of the patients had nerve injuries, which was similar to the study by arthroscopy. So they concluded that elbow arthroscopic surgery is a relatively safe surgery if done cautiously. The outcome is not just dependent upon the elbow arthroscopy intra, but it starts from the history taking per se, wherein a simple example and examination of elbow, wherein we would get some information about the elbow procedures or elbow surgeries if it is done previously, or on examination if we come to know that the ulnar nerve is subluxating more than usual. So these are some of the points the author mentions that we should keep in mind, and also intra-op we should place our portals in such a way, and we should follow the principles of managing managing our devices through these portals, that we stay away from the vital structures around the elbow. So they also concluded that the nerve injuries, which is one of the most debilitating complication, these are in most of the time neuropraxias which recover. So none of the patient had had residual nerve injury in long term, that all recovered. This article by William Stenson and co. published in Arthroscopic Techniques, wherein they suggested how to avoid neurological complications in elbow arthroscopy. As we can see in this diagram, how the important nerves of elbow are in close proximity around the elbow. Though I'll not be going into the detail of portal placements, I'll be just telling how we should be cautious while we are managing or propagate or devising our arthroscope or the shaver through the portals. The first thing which the author mentions, that a prone position and a flexed elbow is very important. That in flexion position, the vital anterior structures are more anterior and far away from our operating devices. And the relation between the medial epicondyle and the scope, that proximal medial proximal anteromedial portal is 2 centimeter proximal. That why it is important that to keep this so much proximal is, we can see in this picture that it keeps the portal away from the ulnar nerve. And also author suggested that before starting the elbow arthroscopy, marking the anatomical landmarks is very important, so that the surgeon would have a fair idea where exactly he is while operating. In these pictures, we can see how the medial anterolateral portal is placed 2 centimeter proximal to medial epicondyle. One important thing the author mentioned here is the anterior border of the humerus, wherein we should not be too anterior to it, neither too posterior. Anterior would put median nerve and the brachial artery at risk, and being posterior would put ulnar nerve at risk. So also the same applies to lateral proximal anterolateral portal, wherein it should be 2 centimeter proximal to lateral epicondyle, and it should not be too inferior that it would injure the PIN nerve. Also, while manipulating the instruments into the joint, we should be careful because the ulnar nerve would be very near while we are managing stuff from medially placed portals. So the author concluded that though the nerves are in close proximity, so the proper placement of the portals and respecting the range of movement of these instruments intra-op should be kept in mind, that we should not that we should not injure any of the neurological structures. And also the author mentioned one important point, that while using a shaver from the posterior posterolateral portal, always the tip of the shaver should
Mark, 1 second, you have been muted by mistake. Mars, can you unmute yourself?
Am I audible now? Hello?
Yes, Mark, you're audible.
I'm audible now? Yeah. Hello, can I continue?
Yeah, you can.
Yeah. While concluding William and Co, they concluded that while manipulating from the posterolateral portal, wherein it's usually directed towards the olecranon and the olecranon fossa, and the process which should be cautious, that just next to it there would be ulnar nerve. So while using a shaver from the posterolateral portal and viewing from the posterior portal, the author has mentioned that there have been reports of ulnar nerve being struck to the shaver if the shaver is not in view of the scope. So blind shaving should not be done in this particular while managing through this portal, that we would injure ulnar nerve iatrogenically. So the take-home message of this particular talk is that there are obviously the advantage of minimal invasive arthroscopic procedures when compared to the open procedures. The elbow arthroscopy comes with a steep learning curve, that a clinician has to spend that much of time in learning these procedures. The pathologies of the ulnar nerve should be kept in mind, and the change in anatomy of the ulnar nerve, it may be because of previous surgery or just the subluxation, but everything should be kept in mind before planning elbow arthroscopy, that we don't injure this nerve, because ulnar nerve is the most commonly injured nerve in elbow arthroscopy. Intra-op, we should respect the principles and the range of our reach in managing the elbow pathologies, that we don't injure the neurovascular structures around the elbow. A prone position and the flexed elbow is most importantly favored by various authors, that the anterior structures fall away from our operative field. While managing shaver, we should make sure that the shaver should always be in the view of the scope, and anterior humeral border is very important while managing from proximal anteromedial portal, that we don't go to anterior into posterior, that anteriorly median nerve and brachial artery would be there, and posteriorly ulnar nerve would be there. So thank you, sir.
Yeah, we'll finish up the next presentation and have the discussion.
Okay, sir.
Good morning, sir. I'll be presenting on positioning and portals in elbow arthroscopy. Introduction. The rate and utility of elbow arthroscopy continues to climb at a rapid pace. Although initially used for loose body removal or diagnostic purpose, current indications, as quoted by previous speaker, are numerous. So along with this growth, elbow arthroscopic techniques continues to be refined and improved compared to the previous generations. So the commonly used positions for elbow arthroscopy is supine suspended, lateral decubitus, and prone. In the prone position, the arm holder steadies the upper arm while the elbow is flexed to 90 degrees and it is held by gravity. It makes the elbow similar to a knee, and it is easy to manipulate the elbow during the procedure. and it is easier to access the posterior compartment, and any open procedures, if it is required, it can be done just by internal or externally rotating the shoulder. However, most elbowscopies can be performed in regional anesthesia, especially in prone position. Conversion to general anesthesia is prohibitive. So the two most commonly used position for elbowscopy is supine suspended and lateral decubitus position. So coming on to supine positioning, the initial description of supine position was published in 1985 by James R. Andrews and co. In this technique, the patient's arm was positioned with shoulder abducted to 90 and elbow flexed to 90. The so-called supine position was further modified in 1995 by Larry D. Field et al., in which the arm is adducted across the body and in a mechanical arm holder, and the arm is positioned in space, and the shoulder is flexed to 90 degree and internally rotated and the elbow is flexed to 70 to 90 degree, thereby accumulate the maximum volume of joint of elbow. Coming on to the strengths and the limitations in supine position, it was done by Christopher Camp et al. The strength in supine position is unobstructed access to the airways for anesthesia, and the gravity pulls the neurovascular structures anteriorly, and flexion extension can be performed without any assistant, and if at all, if an open procedure is required, it can be easily converted. The limitation being it requires a mechanical traction device, and some surgeons feel difficult in orientation and difficult in navigation, especially those who doesn't have a significant amount of experience. And there is a limited access to the posterior compartment. The arm is unstable if it is not positioned and secured properly. Coming on to the lateral decubitus position, as we can see from this picture, the patient is positioned in lateral decubitus, and the optimal positioning is by having the patient leaning forward so that the elbow of the operative extremity extends to fall beyond the edge of the operative table. Following on the strengths of the lateral decubitus position, so it gives improved posterior compartment access, and the elbow is maintained in stable position compared to the supine position, and the traction device is not required. The limitations being it is difficult to access the anterior compartment and the medial compartment, especially if open procedures are required. This is a systematic review by Brandon J. Erickson. In the study, it was found that in Asia and Europe, lateral decubitus position is the most commonly used position for elbowscopy, while in North America, it was a supine position, and the most common indication being OCD, lateral epicondylitis release and debridement, and loose bodies removal. Before coming on to the portal placement, in a study by Curtis Miller et al., it was found that when a joint, this is a non-distended joint, this is the humerus. M stands for medial nerve, R radial nerve, and U is ulnar nerve. C stands for the capsule. So when a joint is distended with normal saline through either the olecranon fossa or through the lateral soft spot, which is between the tip of olecranon, radial head, and the lateral epicondyle, it distends the joint capsule so that the distance between the articular surface and the nerve, it gets increased. When it comes to median nerve, it increases to about 12 mm, and for the radial nerve, it increases to 6 mm, although not significant change has been observed in ulnar nerve. Joint insufflation, when combined with flexion, it increases furthermore the distance from the bone and the articular surface. In the median nerve, it increases from 5 to 13 mm. For radial nerve, it is from 6 mm to 10 mm, and for ulnar nerve, so it increases from 3 to 5 mm. And they concluded that flexion and pre-insufflation increases the distance from the articular surface and the nerve, and it is highly desirable. The things to be noted here is, however, Only little change has been observed in distance between the capsule and the nerve, which confirm the fact that the nerves and the soft tissue tend to move in with the capsule as the capsule becomes insufflated. So what are all the tips to avoid a damage to the ulnar nerve and the cutaneous nerve? So in a study by Joseph et al., it was found that the ulnar nerve is threatened with the proximal medial portal, but it is at risk with any medial portal, especially after ulnar nerve transposition or a subluxating ulnar nerve. So the ulnar nerve is usually palpable under the medial epicondyle, and it should always be identified before making any skin incision. And if it is not palpable, an open medial incision must be performed before inserting the medial portal. So in order to in order to minimize the injury to the cutaneous nerve, in a study by Dowdy et al., he described a nick and spread technique. That is, skin is incised through a scalpel, and then a blunt artery tip is used to create the subcutaneous tissue. And if an inside-out technique for inserting a portal is used, the elbow should be flexed to 90 degrees so that the neurovascular structures are transposed anteriorly because of the gravity, thereby decreasing the risk to the neurovascular structures. Coming on to the portal placement. In a study by Luigi Pedersini, he quoted a 2 centimeter rule. That is, the main working portals are located 2 centimeter proximal to their bony prominence. So the main working portals are the proximal anteromedial, which is located 2 centimeter proximal to the medial epicondyle, anterior to the intermuscular septum. The proximal anterolateral is 2 centimeter proximal to the lateral epicondyle, while the posterocentral is 2 centimeter proximal to the olecranon. However, it is not constant, as the surgeon may need to make some modification in cases of special situation, that is presence of a deformity, advanced arthritis, and depending on the build of the patient. Coming on to the posterior anteromedial portal, it is a commonly starting portal, and it gives good visualization of the coronoid, lateral capsule, and the radial head and the gutta. It is as various modification has been described in the literature in setting up this portal. Lindenfield described it as 1 centimeter proximal and anterior. But recently, senior authors have come for a consensus that it should be placed 2.5 centimeter proximal and 3 centimeter anterior to the medial epicondyle. And while inserting this proximal anteromedial portal, it should be directed towards the radial head, sliding distally over the distal humerus, which keeps it deep to the brachialis, thereby protecting it from the brachial artery and the median nerve. Proximity of the neurovascular structures to this portal was studied by Keith Stothers, in which he found that the medial antebrachial cutaneous nerve is at the most risk because of this portal, which is located 2.3 millimeter away from this portal. While the ulnar nerve is located 12 millimeter posterior and the median nerve is 12 millimeter anterior, and the brachial artery is located 18 millimeter. Coming on to the anteromedial portal, it is an accessory medial portal. It is made 2 centimeter distal and 2 centimeter anterior to the medial epicondyle. Usually because of the risk of neurovascular damage, most surgeons do not use this portal frequently. And the safe way to insert this portal is by a Weisinger rod from the lateral side of the joint. The medial antebrachial cutaneous nerve is the nerve at risk, which is located 1 millimeter, which is much more proximity than compared to a proximal anteromedial portal. So in a study by Tucker Cushing on safety of anteromedial portals, it's a systematic review comparing the safety of proximal anteromedial portal and the standard anteromedial portal with nearby neurovascular structures. In the study, it was found that the proximal anteromedial portal it puts less risk to the nearby neurovascular structures, and it is highly desirable. And when it is coupled with elbow flexion and joint distension, it increases the distance further away from the neurovascular structure, as the neurovascular structure tends to displace anteriorly, minimizing the risk to it. Coming on to the lateral portal, the proximal anterolateral portal is made 1 to 2 centimeter proximal to the lateral epicondyle, and it is directly directed on the distal humerus. After piercing the brachioradialis, the trocar perforates the lateral capsule, thereby entering the joint. The structures at risk, as we can see from this picture, or the radial nerve, lateral antebrachial cutaneous nerve, because of this portal. The PLP is commonly used to a lateral portal as it provides better visualization and it is safer than the other anterolateral portals. The standard anterolateral portal is made 2 centimeter distal and anterior to the lateral epicondyle. As you can see from this picture, the radial nerve, the lateral antebrachial cutaneous nerve, and the posterior branch of antebrachial cutaneous nerve are the risk, or the nerves at risk. Here, the scope is directed towards the coronoid process, and extensor carpi radialis brevis has to be perforated along with the supinator. And they quote an outside technique for insertion of this portal in order to decrease the minimize the risk of damage to the neurovascular structures. Coming on to the third portal, which is the direct lateral portal, it is created in the soft spot of lateral elbow, that is in the center of the triangle formed by the lateral epicondyle, olecranon, and the radial head. The structures at risk are the posterior branch of antebrachial cutaneous nerve, which is located at a distance of 7 mm to this portal. And direct lateral portal provides excellent visualization of the inferior and the posterior capitulum and the radial nerve joint, thereby making it the most desirable portal, especially in patients of osteochondritis dissecans. Here they also describe that the capitular space is very tight, and wrist scope that is of about 2.7 mm can be useful, especially in this joint. This is a study, the randomized study previously I've quoted, comparing the safety of anterolateral and the proximal lateral and the anterolateral portal. In the study, it was found that the radial nerve is in close vicinity to the anterolateral portal compared to the proximal lateral, and it is further enhanced by keeping the patient's elbow in flexion. F stands for flexion. So in a study by arthroscopic anatomy of lateral elbow by Larry D. Field, it was found that the lateral portal placement is most safely accomplished and the most commonly performed after distension of joint with elbow position at 90 degrees of flexion, and it provides greatest clearance from the radial nerve as seen from the study by Stothers et al. And it provides a most complete view of the anterior elbow joint due to its site of insertion and obliquity of its joint entry. Coming on to the posterior portal, the posterocentral and the posterolateral portals are the routinely used posterior portals. The posterocentral portal is made in the midline, the 2 centimeter proximal to the tip of olecranon, with the elbow flexed to 90 degree. Care should be taken that it should not be close to the tip of olecranon, because of which there is a possibility of damage to the triceps tendon. And it is relatively safe portal, about 2 centimeter distance from the ulnar nerve and the posterior antebrachial cutaneous nerve. The posterolateral portal is done. Is made 2 centimeter proximal to the lateral border of olecranon. And while inserting the scope, it is inserted at an angle of 45 degree with the elbow flexed to 90 degree. Usually, the posterior portals are used for loose body removal and the removal of osteophytes. So the take-home message will be from an article by Nick Helgersson et al. On tips to avoid nerve injury in elbow arthroscopy. He has divided into 8 phases. To start off with, it's the workup phase. That is, we have to determine a valid indication, and if at all, if it is needed, additional imaging studies such as CT scan should be done. And we should formulate a habit of routinely reporting subluxating or previously transposed ulnar nerve for all OPD patients. The second stage is preoperative preventive measures. That is, we have to examine the patient and anesthesia, and all the bony marks should be marked, especially the course of ulnar nerve should be marked. And authors recommend to go for general anesthesia because of the patient's comfort and in order to disable the patient's unwanted movements because of their which could still be possible in regional block. And when it comes to patient positioning, the authors recommend lateral decubitus to supine suspended because of the anterior displacement of nerves and easy access to the posterior compartment and the lateral compartment if any open procedures are required. And as I previously said, joint inflation, it increases the distance from the articulate surface to the nerve, which is predominant for the median nerve and the radial nerve. And the elbow position is, elbow should be flexed to 70 to 90 degree in order to increase the maximum distension capacity, thereby decreasing the risk of nerve damage. The portal placements, in a nutshell, portals proximal to the joint tends to be safer, which can be seen in proximal anteromedial and proximal anterolateral. And too many portals should be avoided as it increases the risk of neurovascular damage. And lastly, use of instruments. As quoted by my previous speaker, the tip of the shaver should always be visualized in the field, and suction should be avoided whenever we are in the vicinity of a nerve structure. And retractor should be used in order to lift the capsule when we are doing debridement, especially separating the capsule away from the work site. Thank you, sir.
Thank you. I mean, the experience in elbow arthroscopy is very important before you do the cases on your own, because it's not as easy as the knee or the shoulder. The most important complication has already been mentioned, the neurological complication. And apart from that, there are chances of compartment syndrome also. You have inflated the tourniquet, and then you irrigate the joint, and then as the fluid goes inside, the elbow swells up, and that also can lead to a distal vascular deficit. So spending more time in elbow arthroscopy has to be reduced. And the most important step in elbow arthroscopy is the patient positioning. Ideal positioning, and usually the lateral decubitus position and posterior approach, and you should be able to flex the elbow in this position to at least 120 degrees. So that gives you a good access and also assesses whether your the indications for the surgery is satisfied. Commonest indication is loose body removal and arthrolysis. So when you do arthrolysis, you should be able to put the joint through various range of motion, and the position should help you give this freedom of movement. So the commonest position that I prefer is the lateral decubitus position, so that in case if the elbow arthroscopy is not possible due to very tight joint or multiple loose bodies, I can easily open up and complete the surgery. Next most important thing is ideal portal placement. See, the problem with elbow arthroscopy is the surface marking may not be accurate as we see in case of knee or shoulder, because the bony prominences are quite clear in these two joints. But in elbow, because of the adipose tissue, the bony prominence may not be that clear, and hence there may be a very high chance for you to place the surface anatomy in a different level, and that may also lead to neurological injury. So the general step that I follow is, whether I see the surface marking or not, I usually use a posterior portal, looking through the posterior joint space, and the posterolateral portal, which can be a safe zone because there is no neurovascular structure available over there. And then that gives us a good access to the posterior aspect of the joint. Then what I do is, through the anterior outside in technique, I do an anterolateral portal and then divert my curved mosquito towards the joint and open up, and then put a Wissenger rod and then open up the space in such a way that this is done with the elbow inflection, so that all the neurovascular structures are pushed anteriorly, and then gain access through the scope. And then the anteromedial portal is made from outside in technique, visualizing it from the joint. So that way the ulnar nerve can be prevented from any damage. And always use two portals in the anterior medial aspect. One for the Wissenger rod to keep the capsule separated away from your instrument, and the other one is for the working portal. So if we follow these steps cautiously, we can definitely avoid injuring the neurovascular structures, and can be successful in what indications we have operated the patient for. But every time, elbow arthroscopy has got a very steep learning curve. So what you have to do is go through the basics again and again. If possible, again and again, see the videos. I always, whenever I go for any elbow arthroscopy case, irrespective of the number of cases I've done, I still make it a point to go and watch the Vumedi videos, read the basics, learn the basics again, and then approach the case as if it's the first case that I'm operating. So if you do that, you can definitely avoid any mistakes intraoperatively.
Sir, do you routinely do joint insufflation before placing the portals?
Yes, with the 20 ml saline.
Okay.
Good morning, sir. Good morning, sir. My topic for today is total hip replacement in dysplastic hip. Coming to the introduction, developmental dysplasia of hip is one of the leading secondary causes of the osteoarthritis in young hip joint. It is always important in the developmental age that relationship between the femoral head and the acetabulum is to be maintained well, but in this case, in the DDH, there is abnormal relationship between the femoral head and the acetabulum, which results in the developmental dysplasia in the hip joint. There is no longer that we use congenital development dysplasia of hip. We instead use developmental dysplasia of, because even in the growing age, the dysplasia continues to occur. So it is always used as developmental dysplasia of the hip joint. What are the associations which are associated with DDHs? One is a slipped capital femoral epiphysis and the Perthes disc. These two are the most common association with the DDH. Coming to the etiology, it is present in 1 to 1.5 of 1,000 live births which occur. The positive family history is present in 1/3 cases. It is most common in the most at risk combination is a firstborn female child in a breech presentation. It is always about 80% of the times it is females, in which 60% of the times it is the left hip, and up to about 25% of the patient present in the breech presentation. So coming to the pathoanatomy of the dysplastic hip, as I said before, a dynamic relationship between the femoral head and the acetabulum is very much important in the developmental age. The contact between the femoral head and the triradiate cartilage helps in the deepening the acetabulum and the formation of the in the development of the femoral head and the acetabulum. The triradiate cartilage grows by interstitial growth, and the concentric formation depends on the presence of the spherical femoral head. The proximal femoral growth occurs by the proximal femoral growth centers and also the pull of the muscles in the proximal femur, which helps in the formation of the femoral head. The majority of the dysplasia occurs on the acetabular side, whereas on the femoral side, it is secondary to the dysplasia of the acetabular side. So this is the pathoanatomy. This figure shows the pathoanatomy of the dysplastic hip, which includes the inverted limbus. This is the inverted and the elongated part of the labrum, which occurs in the DDH. And the ligamentum teres is usually thickened and elongated, as you see here. The yellow color is in pulvinar, which is a deposition of the fibrofatty tissue, which occurs in the acetabulum. And this is when there is a subluxation or dislocation of the hip, there occurs the elongation of the capsule, and there also might be the constriction of the capsule. Even the transverse acetabular ligament would be pathologically hindered. Also, there will be the interposition iliopsoas tendon, which occurs, which actually which is difficult, which makes difficulty in reduction of the head of the femur to the acetabular socket. So coming to the what is the history and physical examination, you will have to focus in this patient. So you will have to ask for the birth history, neuromuscular diseases, if present inflammatory disorders, any medication usage or trauma. Usually this patient will complain of the activity related pain. We'll have to ask about the history of activity in which the patient is getting pain. And also expectation of the patient after the surgery is very important. Usually the pain will be localized on the lateral aspect or in the groin, which indicates whether it is abductor fatigue or the labral or the acetabular pathology which is causing the pain to the patient. Coming to the physical examination, gait is very important. You'll have to notice the gait, the type of gait. The chronic gait might be due to the muscular atrophy or ipsilateral knee or the back problems or the neuromuscular disease. Look for the Trendelenburg sign and the abductor function. Look for the quadriceps size, and the strength of the quadriceps has to be documented. And in supine position, note the natural lay of extremities, whether internal rotated or external rotated. It actually says the femoral version of the patient. So range of motion, whether it is painful, mechanical symptoms, whether the range of motion is restricted, with which in case is arthritic change would have already occurred. Snapping of the iliopsoas tendon has to be noted. Leg length discrepancy, whether it is present, has to be noted. Abduction and adduction power and impingement has to be noted. Abduction power has to be noted in both flexion and extension, and also impingement by flexion, intervention, adduction, impingement has to be noted. Apprehension with complete extension and the external rotation, which the patient shows the apprehension, which indicates the instability has to be noted in the patient. So this is the imaging of the, what are the images which will have to be taken while we are planning for the total replacement of the dysplastic hip. This is the AP view, standing AP view, which shows, look for the Shenton's line if it is broken, if the patient is having a subluxated or dislocated hip. The center edge angle, which is seen here, which the line joining the center of the head vertically and the lateral edge of the acetabular. Usually it is more than 25 degrees, which is normal. In case of dysplasia, it is less than 15 degrees. Tonus angle or the acetabular index, which is calculated. The line which is the horizontal line which is drawn along the interteardrop line, that is the interteardrop line, and the line which is drawn from the anterolateral part of the acetabulum, I mean which is the weight bearing area of the acetabulum, which has to be drawn and calculated. So this actually, if it is greater than 10, it indicates dysplasia of the hip joint. So femoral head extrusion index also noted. If it is less than 25 degrees of 25% is a normal, which is if it is greater than 25% of the femoral head extrusion, it indicates there is a subluxation. And also the crossover sign, which is shown here. Usually the anterior and posterior rims doesn't cross over. This is a normal. Well, if it crosses over, this indicates the actually femoral, I mean acetabulum is going to more retroversion than the anteversion. So this is a false profile view, which indicates the undercoverage of the anterior femoral head, which is shown here. So false profile view is taken in the picture, which is shown here, which indicates the undercoverage of the anterior femoral head. So coming to the CT scan, what is the advantage of taking a CT scan in this kind of patients is we can actually note the potential correction which we need for the acetabular and the femoral anteversion, which we can see, and then we can actually template, which is shown here. The acetabular and the femoral templating can be done. And also we can look for the acetabular bone stock, which is present, and if at all, if we need the augmentation and all, can be studied in the CT scan. Femoral canal diameter, usually in this kind of patient, sometimes there is no femoral canal in the proximal femur. In this kind of patients, we can actually study the femoral canal diameter, whether it is narrow or whether the canal diameter is, how is the canal diameter. And also, as I mentioned, 3D templating, which can be done in this kind of patient to actually plan for the acetabular cup placement and the planning for the anteversion in the femoral head neck. So coming to the classification, this is the most important classification, which is Crow classification. Crow was actually a fellow under Ranawat. So this is actually basically a Ranawat's classification. It's classified into Crow 1, 2, 3, and 4 types. This classified according to the proximal displacement of the head or the femoral head subluxation. Displacement, if it is less than 10 degrees, 10%, if it is Crow 1, 10 to 15 is Crow 2, Crow 3 is 15 to 20%, Crow 4 is greater than 20%. So how do we actually know how much is the displacement of the femoral head? First, we'll have to draw a line along the interteardrop line. That is, the interteardrop line has to be drawn, and then the amount of displacement, that is from the interteardrop line and the inferior head neck junction, is just calculated, and then it is divided by the diameter of the femoral head, or the 1/5 of the pelvic height. Usually 1/5 of the pelvic height is considered to be the diameter of the femoral head, and then we can accordingly we can classify the dysplastic head into the Crow classification, either 1 to 4. So this is the X-ray showing the Crow 1, 2, 3, and 4 classification, as I mentioned before. So this is one more classification, which is Hartofilakidis classification. It is classified into dysplasia, low dislocation, high dislocation. In dysplasia, there's femoral head is contained in the original acetabulum. In low dislocation, head articulates with the false acetabulum, which the true acetabulum with the varying degrees. B1 is false acetabulum covers more than 50% of the true acetabulum, whereas in B2, the false acetabulum covers less than 50% of the true acetabulum. In case of high dislocation, the femoral head is completely out of the true acetabulum. And C1, C2, where femoral head articulates in the false acetabulum, whereas in C2, no false acetabulum, the femoral head is found floating within the gluteal musculature. Coming to the surgical aspects on the acetabular and the femoral side. First, coming to the exposure, usually the Crow 1, type 1 and type 2 can be exposed any of the approaches depending on the surgeon preference. It can be direct anterior, anterolateral, or the posterior approaches. Whereas in Crow 3 and 4, posterior approach is actually preferred, or the trans-trochanteric approach is preferred in 3 and 4. Coming to the implant selection, usually dysplastic hip patients will be of small stature and hypoplastic acetabular, as mentioned. Distorted anatomy of the femur and acetabulum is common, and usually small press fit components are preferred. The sizes of the cup, 38, 40, and 42 acetabular cup has to be kept in the shelf, and also 22 head has to be made available, because this will have to, because this implants has to be kept in the shelf because they are in need. And also also keep metal wedge augments, reconstruction ring shells, bulk and particulate grafts with association of burrs of the preparation, and screws and washers for fixing. All these implants has to be kept available, which I'll tell you in the upcoming slide why we need this. So coming to the implant selection, again, usually the ESROM or the modular implants, ESROM from the Depot and the Imperion from the Smith & Nephew, these are the implants of choice because they can we can actually tune the anteversion of the femoral head. So these implants make it possible, and these are the implants of choice. Before coming to the surgical aspects of the acetabulum, first let me tell you the this pictures actually shows the acetabular anatomy here. This is the Hartoclafidis type 1, type 2, and type 3. Here the acetabulum is shallow, whereas the little bit of bone loss on the anterolateral aspect. This is a Hartoclafidis type 2 with low dislocation, where you can see acetabulum, there is a deficiency in superior lateral aspect and also anteriorly. This is a high dislocation. As you see the anterior, posterior, and superior lateral aspect of the acetabulum, there is a bone deficiency, and you can see the false acetabulum which is formed here. This is how the acetabulum changes in the dysplastic hip. So coming to the acetabulum surgical aspect, as we know, there is a deficiency in the superior lateral aspect of the acetabulum bone. Always when you are reaming, concentrate on the cotyloid fossa, that is, concentrate on the anatomical hip center. In a subluxated hip, remove all the bones surrounding the acetabulum, labrum, pulvinar tissue, and the peripheral soft tissues are all excised before reaming. And then medialization of the this thing is very important by reaming the periosteum and the medial wall of the acetabulum, which also increases the coverage. This picture shows this picture shows reaming, which begins in the which begins in the anatomical hip center, that is a cotyloid fossa, which a small reamer, and then increasing diameter of the reamers, which from the anatomical center of rotation. Always avoid reaming the proximal distal dimension in the superlateral deficiency to avoid the anterior and the posterior bone loss, and which causes inability to achieve cup fixation. That is, always go from the smaller diameter, always concentrate the anatomical hip center, that is a cotyloid fossa, and then go on reaming. But don't always aim in covering the superlateral aspect bone deficiency. Aim for about 70 to 75% of the cup coverage, which gives you the better coverage. Sometimes the acetabular augmentation might be required, so metal augments or bulk autografts can be used. The acetabular component is placed in 1 to 2 mm press fit with orientation about 40 degrees of abduction and 15 to 30 degrees of anteversion. So this is a graph which shows when there is a increasing type of the crow type of the acetabulum you see, in type of the dysplastic you see, the anteversion of the acetabular cup decreases. That means the cup goes into more. I mean the acetabulum goes into more retroversion when the type of the crow type increases in its degree. That is the fourth type will have the decreased anteversion. That is, it goes into more retroversion. So this is one intraoperative picture which shows the dysplastic hip, that is oblong acetabulum. There is something called as Pias reaming, that is the reaming should be done from posterior inferior aspect of the acetabulum to the anterior superior aspect of the acetabulum. This directional reaming has to be followed in the dysplastic hip. This is the usual standard reaming which we do from the 6 o'clock to 12 o'clock position in case of the acetabulum, normal acetabulum. In Crow type 1, it is treated similar like a primary osteoarthritis or any other hips. Uncemented acetabular shell is typically used with good results. As I said, medializing the acetabular component within few millimeters of the medial wall will provide better superior coverage. And very important, attention should be paid to the anterior and posterior columns when reaming the acetabulum. This picture shows templating of the Crow type 1. As you see here, the templation is done with the 54 mm cup, which shows there is a little bit of lateral overhang of the acetabular cup. Whereas the templating is also done with the 48 mm cup. This 48 mm cup would actually prevent the breaching of the anterior and the posterior wall. Always prefer for the lower end cup than the higher diameter cup in order to save the anterior and posterior prevent the breaching the anterior and posterior dimensions of the acetabulum. So this is one more Crow type 1 which has been total hip replacement has been done, and here you can see the under coverage of the acetabulum, and the fit is not in the anterolateral part of the this thing where there is a bone deficiency, but it is okay because the coverage is good. About 70 to 80% of the coverage is good, so this is acceptable. So coming to the Crow 2, 3, and 4 types of acetabulum. These kind of patients will have the more bone loss in the superior lateral anterior and ultimately the posterior acetabulum. It is always ideal to restore the center of rotation of the hip, the true acetabulum, and not leave patients with the high hip center. That is the ideal situation, whereas cementless fixation is more durable. Always, as I said, always aim for 70% of the native bone contact with the shell to obtain the reliable ingrowth of the acetabular shell. So if there is inadequate acetabular coverage to place a primary cementless shell, consider placing the acetabular component in the superior location, that is at the high hip center, acetabular component medialization through the medial acetabular wall, or superior lateral augmentation with the bone graft. This augmentation is always considered when there is when the only up to 40 to 50% of the shell is covered and rest of the shell is not covered. So in those cases we'll have to consider the augmentation either with the metal augments or the bone grafts. So this picture shows Crow type 3 with low dislocation artophylacitis. They have done restore the anatomical hip center with the bone grafting, which they have done, which fixed with the screws in the with the screws. So this is one landmark paper by the Muramat and others. They operated on the DDH patients for Crow 1, 2, and 3 dysplasia. 10 cups were placed at the anatomical center and 33 were kept at the high hip center without bulk bone grafting. They showed that there was no much wear difference in both the patients, whereas very little bit of 0.148 mm per year wear rate was actually in the high hip center group, whereas 0.128 mm, which was not much significant wear rate between the high hip center and the anatomical hip center. And the center of the hip horizontal location in the anatomical group and the high hip center group was significantly shorter than compared to the normal hips. That is, the medialization is very important, which this paper says. And they concluded that Moderate high cup placement without bulk bone grafting at a horizontal locus, more medial than that of the normal hip, is an alternative duration solution in durable solution in CRO1 to CRO3 type dysplastic hips. This is one more paper by the Ranawat group. They naming durable fixation achieved with medialized high hip center group cementless THA for CRO type 2 and type 3 dysplasia. They also compared the lateralized high hip center group, where they said that lateralized high hip center group has got more wear pattern when compared to the medialized high hip center group and the anatomical group, but which it was not significant, but both groups had got similar functional outcome, and both group had an excellent outcome. Coming to the femur, before coming to the surgical aspect, we have to know the femoral anatomical changes which happen in the dysplastic hip. The femoral neck version always will be more anteverted, posteriorly displaced greater trochanter, and short offset of the hip. Valgus neck shaft angle we invariably see. Hypoplasia of the intermedullary canal, or even the intermedullary canal would be absent in the proximal aspect of the femur. Rotational metaphyseal diaphyseal mismatch would be there. Contracture of the abdominal. All these anatomical changes would be present in the dysplastic hip. Accordingly, you'll have to manage it. So, CRO type 1 and type 2 femur. Femoral shortening osteotomy is typically not needed in these two type of hips in the CRO type 1 and type 2. Cemented or uncemented stems can be used. Sometimes cemented stems have got several advantages because they are having a narrow implant, and also the version can be tuned because it is cemented, and version can be tuned. More antiversion, if we want, we can actually make antiverted, and then we can fix the implant. But nowadays the stem of choice is the modular stem. We in our institute we use SROM stem in this. We have used in two cases. The SROM stem has got this is after trial implantation. You can actually tune the antiversion with one click. It actually increases or decreases the antiversion, which can actually use to increase the or decrease the or tune the antiversion in our patients when we are operating on the femoral side of the dysplastic hip. So in CRO 3 and 4 femur, acetabular is usually placed at the level of the true is preferred to be placed at the true acetabulum. And if at all you're placing the prepared to shorten the femur to keep it at the anatomical hip center, it has to be kept. So you need a shortening osteotomy in that case. Why we need to bring back, why we need to do the shortening osteotomy in this kind of patients is because of all these reasons. Rectus femoris and hamstring becomes tight, and there will be difficulty in reduction of the hip. The risk of undue tension on the femoral and sciatic nerves is very, very high. Need to correct extremes of antiversion, which is not possible without shortening osteotomy. We have to consider doing a femoral shortening procedure when we plan to length 3 centimeter or more lengthening when it is there. So these are the steps to do the subtrochanteric osteotomy. First, we'll have to neck osteotomy is done. In the case of SROM stem, we'll have to do a L-shaped neck osteotomy. The proximal and the distal rimming is done, and then the proximal sleeve is placed. The trial sleeve is placed, and then the osteotomy is performed, which actually is should be done superior to the attachment of the gluteus maximus tendon as shown here. And then the femoral component is implanted into the proximal aspect of the femur, and then the head is reduced into the acetabular socket, and then traction is elicited on the traction is given on the femoral side. And note how much of the osteotomy has to be performed on the femoral side. That is calculated, and then the hip is reduced now inside the the distal part of the stem is actually inserted into the femoral shaft after the osteotomy, and now the femoral the soft tissue tension is then observed. So after that, the hip is reduced and the further procedure is carried out. These are the steps for performing a subtrochanteric osteotomy. So this picture shows the reduced after performing osteotomy and reduction of the osteotomy. Here, this picture shows the 4 months follow-up of the healing of the osteotomy site with the modular implants in place. So this is the picture of bilateral CRO type 4, where it shows there is osteotomy done along with the placement of the femoral diaphyseal stud graft in place. So we have done in last 5 months, we have done 2 cases. These both cases were about of CRO type 2, which we have accepted the high hip center. This is a preoperative X-ray of the patient showing the CRO type 2 developmental dysplasia of the hip. And we have accepted the high hip center about 4 to 5 above the intertriatal plane, as you said. The implants are in good position, and the patient is up 4 months follow-up and is doing very well now functionally. So this is he's one more case which we have done in our center. 25-year-old male patient. He's also type 2 CRO type 2 with the CRO type 2 dysplastic hip. We have done the again the SROM stem we use. We have accepted the high hip center in this patient as well, and the patient is of 2 months follow-up and is doing well clinically and functionally. So what is the take-home message? Thorough physical examination and the radiological examination has to be done. On the acetabular side, restore the center of rotation of the to the true acetabulum when possible. Medialize the acetabular component to get better coverage. Leaving a high hip center is acceptable if the bone of the true acetabulum is deficient and there is good bone quality superiorly. Uncemented acetabular fixation is preferred to the cemented. Be mindful of AP dimension of the acetabulum, as it will often dictate the size of the acetabular shell. This is very important, and so this will actually downsizing the acetabular shell will actually prevent breaching the anterior posterior walls of the acetabulum. So femur on the femoral side, femoral deformity is not predicted by the dysplasia classification. Cemented stems and distal fixation stems can better correct anteversion and metaphyseal or diaphyseal mismatch. In this case, the modular stems which have the correctable ability, that is the modular stems will have a will be the stem of choice in this dysplastic hips. Subtrochanteric femoral shortening osteotomy should be considered when lengthening of 3 centimeters or more is anticipated in this kind of patients. So thank you, sir.
Avinash, yeah, you covered it very well in all the aspects, which important aspects one should know in dealing with the dysplastic hip. And starting from the pre-op evaluation, radiological evaluation. But as per the recommendation in the papers, actually no need of CT to really execute the procedure and to diagnose the dysplastic hip. But in very few centers, which really you need to assess the bone stock, 3D printing, and to assess the femoral stem version and bone stock, they are doing a CT. Otherwise, routinely by the plain X-ray, which what you described, by basically we follow this cross classification. It's very simple, but basically it will give a practical implication of which type we have to choose, which type of implants and center. So I would like to ask one question: how do you differentiate the patients coming with primary dysplastic with secondary dysplastic hip? For example, if in a post-septic sequelae. So how do you differentiate this patient? Is there any difference in the approach in this patient?
Sir, in case of patient with secondary pathology, I mean, if there is an infection or something, we'll have to anticipate the contracture, soft tissue contracture than the dysplastic hip. The pure dysplastic hip will have less amount of contracture of the soft tissues, or the soft tissue handling would be less trouble when compared to the secondary, like if it is post-traumatic or if it is post-infection pathology. In that case, it has to be differentiated and it has to be dealt separately. In the both the patient, it has to be dealt separately.
In post-septic sequelae, there will be a significant soft tissue contracture. And the difference is that when you're dealing with a primary dysplastic, there will be a hypermobile hip. Usually it won't present with the flexion deformity. Usually it won't present with flexion deformity in primary dysplastic hip. If it is a secondary dysplastic, they have an associated deformity that indicates the patient is a secondary pathology. And when you're dealing with a surgical release, you have to completely skeletonize the femur when you're dealing with a secondary dysplastic, except abductors. So otherwise you have to completely release. So then only you will be able to get the femur back into the socket.
Okay.
Can you understand? So
yes,
in those situations, if you try for a subtrochanteric osteotomy, especially with post-infective or contracture, you will not able to reduce the femur. Can you understand? Because the
Yes.
tissues, it won't lax or it won't yield to get the femur back into the socket. So you
Yes,
should always clinically, when your patient is presenting us, always examine patients properly, get the history, and examination is the key when you are assessing for the patient when you're dealing with a dysplastic hip, whatever the hip you're dealing. So in that, if the range of motion is limited, if they have a deformity, so then you should always keep a caution that, okay, this patient is dealing with primary or secondary. Okay. So,
okay.
and you have mentioned that in 2, 3, 4, there is no high hip center. But now the concept is type 1 anatomical hip center, type 2, type 2 and type 3, you can accept a high hip center. Studies has shown it's a very reasonable good outcome with proper medialization with getting a good coverage. So type 1 anatomical, type 2 and 3 high hip center. So how will you define a high hip center?
High hip center is something we'll have to, the landmark is from the interteardrop line, I mean the teardrop itself, sir. We actually acceptable high hip center is up to about 25 to 30 mm, which has got a good results in the long term. High hip center is something which we go above the lower margin of the acetabular cup, which is much higher than the interteardrop, I mean teardrop.
Okay. Yeah, 1.5 to 2 centimeters. In some journals, even they go up to 2.5 to 3, but accept as 1.5 to 2 centimeters. And you can very well accept the high hip center, and they do very well. And the technique which the mainly we concentrate in the acetabular side is the getting the good bone coverage. And the 70% of the coverage is fit is acceptable. And the preferable choice is uncemented cup with a good porous coated cup. And even in some cases, no need to add a augment with screws. And with in few centers in North America, they used allograft for supporting the defects, but really it doesn't show much difference over the period of time. So always size the cup, and sizing the cup is the key, and never overream, and don't get a false fit in the acetabulum, so that you land up in a very bigger size cup, and that's really not required when you're dealing with a dysplastic hip. And in the femoral side, what you mentioned is choice is a cemented or uncemented one. And in the primary type 1, you can go with the uncemented, or even and then now you have the option of you can play with even the corail stem, with a regular stem, with a low offset stem is also available in type 1. Suppose in type 2 and type 3, if there is a severe dysplastic change in the proximal femur, and type 3, the choice is the SROM stem. And you have seen the two cases. It is very versatile stem, and you have introp the choice of playing with your good version and getting independent of your proximal and distal fixation. So it is if you start using that stem, definitely you'll like to enjoy to use that stem. It's really a very good stem, and the outcome is also shows it has a fantastic outcome with the SROM stem. So this is a very important, but subtrochanteric osteotomy, you should choose wisely when you're dealing with, especially with type 4. If it is a primary, if it's able to, the soft tissue or lags, if you're not able to reduce on table, so then you can decide. But preoperatively, can you make any decision going to theater? Okay, this case is for subtrochanteric osteotomy. Is there any just one radiological finding? So have you read anything like that?
Sir, preoperatively, we can actually, while examination, we can actually give
No.
traction.
I'm asking radiologically.
Radiologically.
So the one simple finding is that if the lesser trochanter of the femur is at the level of teardrop,
Okay,
understand?
sir.
LT
Okay.
of the femur is at the level of teardrop. So you can mentally prepare, okay, this case might require a subtrochanteric osteotomy. So that you can keep in mind, because you should know, because you should keep ready. So once, because in few cases, you have to add the augment, the trochanteric osteotomy with the plate also. So these are the things you have to understand. Otherwise, you have covered it. So yeah, thank you.
Thank you, sir.
Sir, I have a doubt.
Yes.
In Crow type 2 and type 3 and type 4 separate thing. In 2 and 3, do you have to use a long neck, and what is the like? Does it have to be a high inclination, normal inclination neck, high angle, low offset, and do you actually aim to match the LLDs? Like, do you actually aim to get the both limbs in equal length?
No, actually, you see, in the dysplastic hip, the patient used to be adapted for the long period of time with a short limb gait. And here in dysplastic, we never try to achieve the equal limb length. So that is not expected in this dysplastic hip. So never try to lengthen the limb, so by which patient will be totally unsatisfied in the post-op.
Okay.
So always we'll try to restore the normal anatomy, and you can achieve of 1 to 1.5 centimeter, but we are not shooting for an equal limb length here.
Okay, sir. And so what about low offset or high offset, or you aim for a high angle of
And whatever the anatomy, that's what the preoperative planning. What is the native anatomy of this patient with offset, and I'm going to restore that. Doesn't matter, I'm not going with a low or high offset. In this case, they won't accept a high offset. Usually they come with a low offset. That's what we preferring a SRAM type of stem.
Okay, sir.
Yeah.
Sir, Jeet here, sir.
Yes, Jeet.
Yeah. So how do you decide the intra-version of the acetabulum and the femoral both side what will be the adequate for this patient? So
the introp landmark is always a TAL, TAL for the acetabular side to get a good version with inclination, and the femoral side will dial with the option. We'll put a trial and see which is the best position the hip is stable. So we'll never go with a fixed, okay, this is we have to give a 15 degrees, not 15 degrees. We might reduce the version because already this is an antiverted stem in the femoral side proximally. So you have to dial the version, put a trial and see before placing the final component. So if this is the best position, accept and mark it with a cautery. Then you have to place the original component.
So usually what do you found, what you have found so far, means what is the position, what version is mostly you have found adequate for this kind of patients?
That's what this is usually what in the dysplastic hip. Whenever going with, I usually refer with a TAL, and I try to keep in a more of an anatomical center, and the acetabular side, which is the best coverage with the best position, referring to the TAL I used to keep, and we'll try to reduce if it is in a overly antiverted and shallow cup, I'll try to keep it in a more anatomical with inclination, targeting for around the version is around 15 to 20 degrees, inclination around 40 to 45, the cup side. The femoral side usually between the around 5 to 10 degrees, not going for a 15 really. I'll try to reduce the version and keep. Yeah.
Okay, thank you, sir.
Yeah. Thank you.
So have you ever found the TAL to be distorted in these cases?
No. It's always, it will be available. It's a very good introp anatomical landmark. It should be there. You'll be able to identify that. And you will be able to identify the pullunar fat pad, the cartilage fossa fat pad will be there, so that you can identify the real true floor of the anatomy in the acetabular.
Okay. Sir, in case of bilateral, if it is a bilateral, say for growth type 3 or something like that, we still have to keep it, if you're operating on the one side, we still have to keep it the offset as valgus offset, or should we have to?
I didn't get your question.
Sir, if you're say if there is a bilateral type 3 growth type 3, if you're operating on one side, so the version, I mean, the offset is always too much of valgus. So we'll have to keep it we'll have to keep it as a valgus offset, or we'll have to.
There are two offset available in the SRAM. So one is a short offset and one is a medium offset, 30 and 36. So it depends on the introp, your soft tissue balancing and tension, what you achieved on opposite side. You have to restore the same thing in this opposite side when you're operating. So that's the advantage of modularity. That's the advantage of keeping modularity introp. And when it's a bilateral, you have to calculate the hip center by doing a Ranawat methods of calculating the hip center. So that is important when we're dealing with the bilateral cases.
Okay, sir. Okay, sir. Thank you.
Thank you.
If no more questions, good discussion in Plus V. If no more questions, we shall end the session. And Jeet, hope we'll meet you in the next online class also next Tuesday, if you're free.
I don't think so, sir. But okay, I'll try.
Advance wedding wishes.
Thank you, sir.
From all
Thank
of
you
us
very
here.
much, sir.
few of us
Thank you,
will
sir.
represent.
Yeah,
Vastavan there.
advance wishes, Jit. Yeah.
Thank you, sir. Thank you very much.